I am live. I started reading Many Lifetimes by Joan Grant and Dennis Kelsey, Joan Marshall Grant. And yesterday I recorded on my laptop, but it was a bit echoey. So this is my mobile. I hope it works better and the sound is a bit clearer. This is Chapter 2, Recognition of a Reality by Dennis Kelsey. He was Joan Marshall Grant's husband. She had more than one husband, and this book was written by them together. It's basically a study into reincarnation. He was a therapist as well. I should like people to share my belief in reincarnation. I think it will cause them to be much happier, much less frightened, and much more sane. For a psychiatrist to hold this belief and to have made it the basis of his therapy is rather unusual. It's not a belief which I've always held, so I will begin by explaining how I was led to it, through clinical evidence, which had been accumulating during the 10 years before I learned that somebody called Joan Grant was able to remember many of her earlier lives. Without this work, I would not have been able to so rapidly to appreciate the value of what Joan was able to contribute, because like so many people, I cannot accept a concept unless it satisfies my intellect and relates to my empirical experience. I was precipitated into the practice of psychiatry at the age of 31 without even an hour's warning. In this I was fortunate. It meant that I approached the subject without any preconceived ideas. For when I was a medical student, psychiatry played only a very small part in the curriculum. I remember being taught that the causes of thyrotoxicosis were sex, sepsis, and psychic trauma. And I attended a series of lecture demonstration, but rather light-heartedly, because questions on psychiatry never occurred in the examinations, and that, to the best of my recollection, was that. But immediately after embarking upon psychiatry, a series of cases came my way, which, step by step, extended the framework of what I believed to be fact, until, after 4 years, a session with a particular patient forced me to the intellectual certainty that in a human being there is a component which is not physical. To be taught this as a matter of dogma or doctrine is one thing. To be compelled to the same conclusion by one's own experience is quite another. I did not realize it at the time, but this session was an important landmark on the way to a belief in reincarnation. At least I had got as far as believing in the reality of something which could reincarnate. In 1948 I was working on the medical side of a large military hospital, a post which I owed to the fact that 3 years previously I had passed the postgraduate examination, which is the part of the long road to recognition as a consulting physician or internist. I was still travelling this road when an epidemic of influenza hit the hospital and abruptly changed my course. One of the first casualties was a medical officer in the psychiatric wing, and I was asked temporarily to take over as much of his work as I could. Late that night I learned that I had an aptitude for inducing hypnosis. I was summoned urgently to the ward to give a sedative injection to a patient who had suddenly become acutely disturbed and violent. By the time I arrived, 3 muscular orderlies had the situation under control and were holding the patient firmly down on his bed. I had a feeling that he was unlikely to resume his violence, so I motioned to the orderlies to leave. But the patient was obviously still very frightened, and with no intention beyond trying to calm his fears, I sat down beside him and began to talk to him in what I hoped was a soothing and reassuring voice. I certainly did not realize that I then began to use one of the standard techniques for inducing hypnosis. It had simply occurred to me that I could get him to fix his attention on something outside himself. He might be less disturbed by his ideas and feelings, so I asked him to fix his gaze on a dim light in the ceiling above his head. For the same reason I coaxed him to concentrate upon his breathing, making it perfectly regular and rhythmical, but a little slower and a little deeper than usual. He was still very tense. His fists were tightly clenched, and his arms and legs showed a fine tremor. So I drew his attention to each of his limbs in turn, urging him to relax them and to allow them to remain relaxed. These instructions were interspersed with reassurances that he had nothing to fight, nothing to fear. Gradually he became perceptibly calmer, until he was lying completely relaxed. Purely for good measure, I continued talking to him in the same strain, and I recall suggesting to him, quite casually, that he might as well go off to sleep. At this his eyes rolled up and his eyelids came down in a curiously positive way, and I suddenly realized, to my astonishment, that I must have hypnotized him. The next morning I described the incident to the psychiatrist in charge of the department, who confirmed that this was almost certainly what had happened. He was intrigued as I, and asked me to repeat the technique on another patient, a man who was suffering from neurosis as a result of a horrific accident with an automobile. This patient entered hypnosis very quickly, and with a tremendous release of emotion relived the circumstances of the accident. The psychiatrist assured me that it would now be a simple matter to clear up the residue of the neurosis. During the next few weeks I was able to treat several other patients in a similar way. They too relived the irrelevant episodes with great release of emotion, and went on to a rapid recovery. I found these experiences in the military hospital so rewarding that I decided henceforth to specialize in psychiatry. Once back in civil life, I took a post in a mental hospital, where I remained for the next 6 years. Hypnosis has played such a large part in the experiences I shall shortly describe that I will say something about it. A convenient starting point is the widely accepted concept that there are 3 distinct compartments of mental activity. First, there is the compartment of consciousness, to which I shall usually refer as normal waking consciousness. This contains only the thoughts and sensations of which we are aware at any present moment. Next, there is the compartment known as the preconscious. Here is stored energy memory, every item of knowledge that can be summoned to consciousness at will. Thirdly, is the compartment with which a psychiatrist tends to be especially concerned, and which is usually called the unconscious. The contents of this compartment lie behind a barrier, the precise nature of which is not known. It may prove to be essentially chemical, electrical, or even purely psychological, but whatever its nature may prove to be, the effect is that material which lies behind the barrier can be brought across it into normal waking consciousness only with considerable difficulty. Hypnosis is sometimes loosely spoken of as sleep, but this is inaccurate. Indeed, unless a specific suggestion is made to the contrary, a person under hypnosis may be unusually wide awake, in the sense that his powers of perception may be abnormally acute. But since such a person is not in a state of normal waking consciousness, perhaps the best description of hypnosis is a state of altered consciousness. An important feature of this state is that it weakens the barriers which confine the contents of the unconscious. This can be of particular value in psychiatry, because it may enable the therapist to bring material from the patient's unconscious to the surface much more quickly than would otherwise be possible. I have always considered myself fortunate in that at a very early stage I encountered a patient who illustrated the reality of the unconscious and the power of material held in that compartment in an unforgettable way. The patient was a young woman who was wheeled into the ward in a chair because she had lost the use of her legs. A few days previously she had awakened in the morning to find that they were completely paralyzed. Examination showed that there was nothing wrong with the nerves or muscles or bones, and that this was a paralysis of psychological origin. In conversation she was clear-headed, calm, and indeed rather cheerful, surprisingly so, for someone who, on the face of it, might never be able to use her legs again. We discussed many details of her life, including the fact that since her marriage she had become very disillusioned about her husband. However, for the previous year life had not been too bad, because he had been abroad on business. Then, almost casually, she mentioned that a few days before the paralysis had occurred, she had received a letter which made her feel obliged to join him. She admitted that she was a bit scared at the prospect, but her principles demanded that nonetheless she should go. She added that her parents would be terribly distressed to learn that all was not well between her husband and herself. Her voice had been level and matter-of-fact as she was telling me this. There was nothing to suggest a young woman striving to speak coherently while in a state of acute fear. But under hypnosis, when I brought the conversation around to her forthcoming trip, a very different picture emerged. She was not simply a bit scared, she was terrified. And as details of the conditions she expected to find at the end of her journey also emerged, her fear was understandable. She was weeping and trembling, but through her sobs I heard her exclaim, "I would rather have no legs than have to go." I then brought her slowly back to normal waking consciousness, insisting, as I did, so that she remembered all that she had been telling me. Now that the full extent of her fear was in consciousness, she was scarcely recognizable as the poised young woman who had been wheeled into the ward. But now her problems were where we could explore them and cut them down to size. We were able to discuss in exactly what respect her parents would be distressed to learn the true state of affairs, and it was not difficult to get her to consider rationally whether it was really necessary to stay with her husband. I was able to remind her that she had earned her living before her marriage and could easily do so again. By the end of this session she was very much calmer and already had some power of movement in her legs. During the next few days we had further talks along similar lines. Suddenly she declared that she had realized the significance of the paralysis of her legs. It was the only way in which she could avoid joining her husband without feeling that she was betraying what had been her principles. Within days after this session her legs were functioning perfectly normal. I do not know if the wish to lose the use of her legs had ever been in her normal waking consciousness, but if it had been and had remained entirely at that level, she would have been able only to fake a paralysis, a performance which she would have found impossible to sustain. But because it was flourishing in her unconscious, I was afforded a vivid demonstration of a principle which is often crucial in psychiatry, that an unconscious wish, if it is sufficiently powerful, may produce an effect that is tantamount to a physical fact. For her legs, temporarily, were as useless as if they had been amputated. This case was instrumental in focusing my interest on an analytically orientated approach to psychiatry. I use this rather cumbersome phrase because while I acknowledge a debt to psychoanalytic theory, it contains certain cardinal principles which I have never been able to share. Therefore, to describe my work as psychoanalysis would be inaccurate and incidentally unjust, both to the psychoanalyst and to myself. Very briefly, I accepted the concept that the memory of an event, which includes the sensations and emotions associated with it, might be stored in either the preconscious or the unconscious. If it were stored in the preconscious, from which it could readily be summoned to consciousness, then it became part of the total experience upon which the individual could base future decisions. The majority of our memories fall into this category, but those which are associated with so heavy a charge of unpleasant feelings that they would make life too uncomfortable if they were liable to recur unbidden to our awareness are relegated to the unconscious. Such feelings are not integrated, and instead of contributing to the source upon which in which comprise the symptoms which we call neurotic. One of the basic principles of therapy is to extricate these feelings and memories from the unconscious so that they can either be integrated or dissipated and lose their power adversely to affect the personality. For this purpose I found the technique known as hypnotic regression particularly valuable. To get a picture of what happens during a regression under hypnosis, consider the two ways in which a person in normal consciousness may speak of an incident which has happened to him. From his position in the present, he may simply be describing something which occurred in the past. In this case, he will use the past sense, saying, I was angry, I was frightened, or I was amused. But he may become so caught up in his story that he slips into the use of the present tense, and his gestures and the tone of his voice reveal that he is virtually reliving the episode. Either he has brought it up to the present, or, and this may be the more apt explanation, he has temporarily left the present and merged with himself with the past, which for him is still extant. Regression under hypnosis is an extension of this latter process. The subject may not only relive the incident as it occurred, but because of the breach which hypnosis may make in the barrier surrounding the unconscious, he may recover details of the event and become aware of emotional facets, of which, on the original occasion, he was conscious only momentarily. A vivid example of this mechanism was provided by a teenage girl whose relationship with her parents was going through a very difficult phase. I had induced hypnosis for the first time during her therapy, and simply to provide a starting point for the session. I asked her the name of her favorite tune. I don't know any, she replied. This surprised me because one of her mother's complaints had been that her daughter spent far too much money on gramophone records. Discs. I asked her how old she was. I'm 5, she said, and then burst into tears. She was already reliving an incident which had occurred when, at the age of 5, she had fallen off a pony, of which she was terrified. Her parents were urging her to remount. She was convinced that they were doing so only in the hope that she would fall off again and be killed. The important feature of this regression was that although in normal consciousness she could have remembered falling from that pony which she had distrusted and feared, the conviction that her parents wished her to die caused greater anxiety than she could tolerate, and this aspect of the incident, which was psychologically crucial, she had buried in her unconscious. Such a spontaneous regression is rather unusual. Far more often a regression is initiated by a specific suggestion from the therapist. I would tend to use this technique when the patient expresses feelings which seem grossly out of proportion to the event he is describing, for this is nearly always an indication that it has significance for him in addition to its face value. If the patient agrees that there is a question to be answered, I induce hypnosis and make a suggestion such as, I am going to count slowly up to 10. While I am counting, you will go backwards in time, becoming younger and possibly smaller. When I reach 10, you will find yourself back in some situation which will help us to understand why the episode you have been describing meant so much to you. On other occasions, having induced hypnosis, I would start the session by using one of the so-called projection techniques. I would ask the patient to visualize a blank cinema screen and then tell him that at the count of 10 a picture would appear on it, which we would take as our starting point. When he had described the picture, I would use regression to help us to understand its relevance. An apparently trivial episode may prove exceedingly useful. A girl of 19 found herself back at the age of 10, playing ping-pong with her brother. I asked her the score. Without hesitation she replied, 1917. She was looking worried, so I asked what was the matter. She answered, I think I am going to win, and he always gets so cross when I do. Suddenly she brightened up. Thank goodness, the dog has come in and we must stop playing because the cat is here already, and they will always fight. This small scene led us to her intense rivalry with her brother, which was an important factor in her illness. The task of a therapist is to use his understanding of a particular case, his knowledge of psychological mechanism, and his intuition to judge whether an incident to which the patient has regressed is relevant or simply a cover story. In any event, the patient seldom reaches the crucial situation at the first attempt, and it is usually necessary, following approximately the same procedure, to induce him to go back still further. I had become accustomed to seeing adult patients reliving events which had occurred when they were only 3 or 4 years old, when a patient regressed to the age of 2. She found herself being taken into her mother's bedroom to be introduced to her newborn brother. Fury was mounting within her at the sight of a baby nestling happily in the arms of her mother, when the nanny noticed a rash on her neck. The nanny, suspecting measles, whisked her away to the nursery. Measles, it proved to be. In a sad little voice, the patient declared, I'm hot and sticky and red all over. She interpreted her symptoms as the outward sign of the hostility she felt towards the new baby, and believed that she was being isolated as a punishment. Shortly afterwards, the same patient provided me with an experience which transcended anything I had previously encountered. The session had begun in a perfectly ordinary way. I had induced hypnosis, asked her to see a cinema screen, and on the screen to see a number. The number she saw was 5. I asked her if the number 5 meant anything to her. She thought for a moment and replied, only that I have 5 fingers. Anything special about your fingers? Only that I bite my nails. Nail biting sometimes has a psychological significance, and I felt that this might be a clue worth following up. So I told her that at the count of 20 she would be back in a situation which would throw light on her nail biting. She found herself sitting in her pram, aged 9 months, wearing only a hat and biting her thumb. This regression was already to an earlier age than had been reached by any of my patients. Yet I felt sure that there still was more to be uncovered, so I told her that she would go further back to a time when she was biting something else. Even as I was counting, she was becoming very red in the face, pummeling the wall with her hands and making violent sucking motions with her mouth. I asked her to tell me what was happening. My mother is holding me to her breast to feed me, but there is no milk coming out. After some moments she gave a start of surprise. Again I asked what was happening. She has put me over to the other side. The sucking and the pummeling of the wall were resumed. Then there was another start of surprise, followed this time by a wail and tears. She's put me down and gone away. A few days later I had an opportunity to discussing this session with the patient's mother. She decided at once that the incident could very well have happened. She had been unable to produce any milk, and in the hope of stimulating a supply had put the child to the breast at each feed before giving her a bottle. But on the advice of her doctor she had discontinued this practice after 3 weeks. She was quite sure that she had never spoken of this to her daughter. Indeed, the whole matter had seemed so trivial that she doubted if it had been mentioned to anyone. She was entirely justified in considering it trivial. Innumerable infants must have had a similar experience without any ill effect whatsoever. It had become significant only because of the way in which this patient had reacted to it. This reaction was in fact quite complex. During the next 2 or 3 sessions I regressed her repeatedly to this incident, and it gradually became clear that although her mother had put her down and gone away only to fetch her bottle, the child had seen this in a completely different light. She had believed that her mother was deliberately withholding the milk, and that the anger she had felt on this account had caused her mother to vanish. Understandably, she developed a very exaggerated idea of the power of her anger, and this was a basic factor in her illness. As she gained this insight, her illnesses rapidly receded, and as she had not had a relapse in more than 15 years to a condition which, with occasional intermissions, had crippled her life for the previous 10 years, it seemed justifiable to say that she was cured. It is pertinent under the circumstances to add that at the hospital where she had previously been treated, she had been advised that her only hope of relief lay in the operation of her leucotomy. I had never felt any doubt that this patient's regression up to the age of 3 weeks had been genuine, and taking the other factors also into account, it seemed to me that I had irrefutable evidence, not merely that the mind was capable at this early age of registering and recording events, but that it was capable also of a complex reaction which might be the source of a neurosis in her future. To put the point the other way round, it seemed there was no doubt that a neurosis might result from the way in which an individual had reacted to an event when only 3 weeks old, and that through hypnotic regression it was possible to bring this event back to normal waking consciousness. With this in mind, during the next few months, I caused the number of patients to regress to this early age, and it became abundantly clear that their ability to do so was not even unusual. The patient who took me the next step forward, perhaps I should say backwards, was a woman of 40. She had been under treatment for several weeks when a session occurred in which she relived the experience of her birth. I had started the session by inducing hypnosis and asking her to see a picture. She saw the sand dunes as they appeared from her bedroom window at home, and as she uttered the words sand dunes, a strain of thought flashed through my mind. Sand dunes, shifting sands, here today and gone tomorrow. Excellent symbol of insecurity, worth exploring. So I said to her, at the count of 10 you will be back in a situation which has for you the same emotional significance of these sand dunes. I had no idea what her response might be, but when on reaching 10 I asked her where she was, she replied, I am 13 at school. All the other girls are wearing summer frocks, but I'm still wearing a winter one. I feel very embarrassed and out of place. I asked her to go back further. I am 5, I'm at a party and I want to go to the lavatory, but all the grown-ups are strangers and there is no one I can ask. I feel hot and uncomfortable. Still further back, she finds herself in a basket of her brother's bicycle. He is taking her for a ride and swerving too fast round the corner. She feels very unsafe. At 6 months old, she is in her pram being taken for the first time outing in the dark. The way lies through an avenue of pine trees which are swaying and creaking in the wind. She fears that one of the trees will fall on her, and is very frightened. At the age of 3 weeks, she finds herself in her mother's bed. At this point came one of the small but intensely personal touches, which, on its observing a regression, gives such a strong sense of validity. She is in her mother's bed because she has an earache. My mother is putting her nipple in my ear to soothe it. I asked her to go even further back to a time when she felt the same tone of emotion. She said, I'm very tiny. I seem to be lying on something very soft and white. I'm very comfortable, but somehow it is not right. I used to be part of a oneness, and now I am separated. At this, I told her that at 10 she would find herself again part of the oneness. As I reached 10, she said quietly and positively, this is the womb. She went on, there is something beating in me, and through me, my mother's heart. I can't see it, and it feels as if I have got no mouth. I asked her in what position she found herself. She replied, curled up Her assumption of this attitude intrigued me. From time to time, this patient suffered from a pain in her hip, which was accompanied by a pain in her head, and had been subject to it for as long as she could remember. She had consulted numerous doctors, but none of them had been able to either to account for or to relieve it. If an attack of the pain came while she was standing up, it would induce a particular gesture. She would put one hand on her head, the other on her hip, and arch her back in a peculiar way. At the same time, her face always assumed the same expression of acute distress. As nearly as her position curled up on the bed would permit, this was the posture and expression which she was now intermittently displaying. Fearing that this stage might be as protracted as during the original confinement, I intervened and told her that she would move forward to actually leaving the room. She began to moan from the pain in her head, and then, just as one felt that her head must soon emerge, she suddenly gasped, "I can't breathe," and appeared to be fighting